بسم الله الرحمن الرحيم. Good morning, everybody. I welcome you to the first session of the second day of this obesity conference. Today we have two presentations this morning. Are going to be presented by two distinguished international speakers. I would let Dr. Excuse me, I have two. Is it in the one? Is it? This is not the program, is it? Oh yeah, because the program is okay. Because we have on the screen different names. Okay, I'll let Professor Kevin Syke introduce our first speakers.
Good morning. Can I introduce Professor Louise Bauer to give the first talk, Managing Childhood Obesity, Evidence, Clinical Guidelines and Implementation. Louise.
Thank you. Thank you for the opportunity to discuss this issue. This sounds quite straightforward, but it's actually quite challenging. The issue is, what do we know about how to treat, and when we do know something, how do we go about implementing guidelines for treatment? This is actually far more complex than you might otherwise think. I'm going to talk about the evidence for treating child and adolescent obesity. I'm going to talk about an overview of the recently published 2009 Cochrane Review, and I'm going to highlight some evidence gaps. I'm going to then talk about clinical practice guidelines and some of the issues about implementing these and why they may not be taken up by clinicians. And then I'll talk about the implications, the evidence gaps relevant to Saudi Arabia, and approaches to implementing clinical guidelines that may work. So let's look at the 2009 Cochrane Review on the treatment of childhood and adolescent obesity, which was published in the January issue of the Cochrane Review, and I was one of the authors. This was an update of the 2003 review. This is actually the most frequently downloaded Cochrane Review on the Cochrane site, the previous one. And this time we decided to include randomised controlled trials aimed primarily at treating obesity in people up to the age of 18. We decided to look also specifically at interventions for people under the age of 12 and those for the people over the age of 12, with the concept that maybe there were some specific issues relevant to adolescents as opposed to younger children. To be included, at least for drug and lifestyle interventions, you had to have at least 6 months of follow-up. And for the first time, we included drug therapy, and we were interested in, as it so happened, it included orlistat, sibutramine and metformin, and the drug therapy had to be given for a minimum of 3 months, and there had to be a 6-month follow-up. We also, for the first time, considered bariatric surgery. And in order to open up the possibility of including bariatric surgery, at least in the future, we decided to include, in addition to randomised controlled trials, we wanted to include controlled clinical trials, controlled before and after trials, or interrupted time series trials, which was expanding the type of evidence that we might include. At this stage, there are no such studies. There are a number of growing numbers of case series and so on, but at this stage no published such trials. So bariatric surgery in this instance is not further considered. Well, with those criteria, we looked and we identified about 6,500 papers on title and keyword search. It's a whole and long and tedious process doing Cochrane reviews, and you need to have at least one PhD student who's going to do it. Do not take it on lightly. It is like marriage, not a thing to be entered into lightly. We looked at, in more detail, at about 206 of these papers, and in the final review we had 64 separate trials. 54 of them were lifestyle intervention and 10 were drug trials. So what were the main findings? And I'm going to show you. We looked at family-based lifestyle interventions, and they can be effective. Family-based lifestyle interventions with a behavioural program, which was aimed at changing diet and physical activity, was shown to provide significant and clinically meaningful decreases in overweight in both children and adolescents compared to either standard care or self-help in both the short term, which was 6 months, or 12 months. There was only a few that went to 2 years or more. So because we actually had enough this time, we were able to do meta-analyses. So for those who aren't, this is a forest plot, and so at the top you can see this is a comparison of lifestyle intervention versus self-help or control, not receiving much, for children under the age of 12 years. Here you can see here that we're looking at you can see here that we're looking at change in BMI standard deviation score, or Z-score, at 6 months follow-up. We've got the 4 different studies. I'm a co-author on one of these papers, which is the one that didn't have the significant findings. And you can see the number of patients in each of the studies. And this is looking at the mean difference between the group, the treatment intervention and the standard care. And you can see how one here favours behavioural group intervention and the other favours standard care. The size of the dots corresponds to the size of the sample size, and you can see the mean and the 95% confidence intervals. And this diamond at the bottom is actually the weighting-related summation of the findings from all of those 4 studies, showing a slight but significant improvement that in BMI standard deviation score in those who took part in the behavioural intervention. So that's a typical forest plot. This next one is for children greater than or over the age of 12 years, this time using BMI. And look, there's a large number of meta-analyses, and I just decided to show you just a handful of them here. And again, you can see we've got this time 4 studies, and you'll be pleased to know, Maury, that none of these ones were by Leonard Epstein's group. And what you can see is that there is about a 2-unit decrease in BMI at 6 months for adolescents following a lifestyle intervention program. In these very reasonably carefully done randomised controlled trials. We also looked at obesity pharmacotherapy, and we had enough data to do meta-analyses for both orlistat, which some of you know is the pancreatic lipase inhibitor that actually basically causes fecal fat loss, and actually is a medication that most adolescents find very unpalatable, very distasteful, and like Maury yesterday, my patients also profoundly complain about it. It's not one that they normally use. Nevertheless, in the studies that have been done, they've been shown to lead to a decrease in BMI in the context of a behavioural lifestyle change. We also have sibutramine, which is a centrally acting appetite suppressant. One of the comments here was that the therapy needs to be weighed up against the potential for adverse events. And the significant adverse events for sibutramine, of course, are cardiovascular, tachycardia, hypertension. So here we have the results for orlistat, and we included 2 studies. This is a change in BMI at 6 months, not a huge change, but certainly an improvement over placebo. And here's the data for sibutramine, and there was about almost a 2-unit decrease in BMI at 6 months on those who were on sibutramine. So not dramatic, but certainly a significant change compared with no such therapy. But there's a number of limitations, and I may have alluded to some of those. So we need to be careful in extrapolating from these studies, many of which were done in volunteers who complied with the stringencies of a randomised controlled trial into ordinary other clinical practice. It'll vary depending on such things as social, ethnic and economic circumstances, and there's huge variations in the availability of resources for local health service delivery. So just because it worked in a randomised controlled trial in the USA or Australia doesn't necessarily it's going to work in either clinical practice in those countries or clinical practice in Saudi Arabia. We need to think carefully too about the validity of these studies. Several of the studies had small sample sizes. There could be study biases, of which we're unaware. There were relatively high dropout rates, but most of these studies that we included really did have what's called an intention to treat, so they actually kept in the analysis all those patients who didn't go through right to the end of therapy. And there may be a whole number of other issues in terms of validity. And there may also be sampling problems. As I alluded to, the majority of research in the field has been conducted in motivated, middle-class, Caucasian populations, although there have been some studies looking at more vulnerable populations, but not nearly enough, and certainly none from the Middle East. There's a need to look, if you're going to do these studies, to look at important psychological and social outcomes. So many of these have not actually been directly measured, and so we're not quite sure what the findings are. And really, other than the drug trials, which actually looked at these very extensively, adverse events of the interventions were very infrequently considered. Maybe there are psychological side effects. Maybe the family becomes more stressed. Maybe it's expensive. We don't know. They haven't been measured. And reporting of outcomes beyond 1 year is actually very limited. So for all that work, we've got a number of things. So we also identified evidence gaps, which are important in terms of considering further research. So, for example, we really don't know what interventions work best for different levels of obesity severity, mild, moderate, severe, different ages, a 5-year-old versus a 14-year-old, and developmental stages, what works in developmentally disabled young people. What about you do your intervention, people lose weight, but that's, you've done your 6 months intervention, but what about out to 2 or 3 years? What about your long-term maintenance therapy? There's very few studies looking at that. Very interestingly, and particularly of relevance here, is the issue of specific ethnicities, religious groups, or culturally diverse populations. Just because it works in middle-class Americans or Australians, is it going to work in places such as Saudi Arabia? We raised a number of other issues. What family characteristics promote weight outcome success? And if you know those, how can you identify them or perhaps help to modify them in some ways through maybe increasing motivational counselling? Issues about self-esteem and the family's capacity to change behaviour. One of the issues which is dear to my heart, what are the most cost and resource-effective methods of treating paediatric obesity in different healthcare settings? You could be in a place that's got lots of money, where lots of people come, where there's a lot of specialists, but what about the reality? We were hearing it yesterday from Bob, diverse population, people in long distance. How do you actually try and treat these people in an effective way? And very importantly, what is the role of bariatric surgery in the treatment of severely obese adolescents, and what are the potential harms as well as the benefits of different interventions? So we raised a lot more questions than we answered through the Cochrane Review. There are lots and lots of research questions. Essentially, we know quite a bit, but there's still a huge amount more to find out. So how do we put the known but still imperfect evidence into practice? Because we've still got all these people who need to be treated. Well, when people think about this, they think about clinical practice guidelines. We'll put together some guidelines and people will do what we tell them to. And when you go and look at the guidelines on the internet, you find that there are guidelines for every purpose known under the sun. And to some extent, I suspect we're guideline insensitive. There are huge numbers of them. And many of you might reflect in your own clinical practice just how many guidelines might come through your practice, whether they, some of them might actually prop up your computer monitor. Some of them may be used for all sorts of other reasons. I suspect there may be a whole lot of reasons why we're going to. I think there's some real challenges. Let me give you a short, somewhat cynical history of obesity guidelines. The NIH came originally out with their guidelines about about treatment, and they certainly have been updated since then. But in 1998, there was no published evaluation of these guidelines. There was certainly very good internet information that gave you practice guide, patient guide, BMI calculator, and CME points, but how much this was taken up, I'm not sure that anybody quite knows. If we go across to another continent, go to the Scottish Intercollegiate Guidelines Network, and can I say these are really good, thoughtful guidelines. There's a lot of useful stuff there. These were published in 1996. They've had no published evaluation. In the Netherlands, in 1992, when they actually went, they published their guidelines then, but there was, when they actually did go and ask of GPs what they knew about it, 75% were unaware of their existence. And when you went to Australia in 2003, we had at that time, the most extensive guidelines known in the history of humankind to do with obesity. I was involved with a little bit of it. And they were developed, and they were a really good state-of-the-art discussion about what was going on, but there was absolutely no funding for dissemination or training of health professionals and other, of both physicians and other health professionals. There was no evaluation, and we know that there was very little uptake. So that can be after all that work, it can be very saddening. The history of obesity guidelines implementation is not very encouraging, but in fact, they're not that much different from the history of implementation of a lot of other guidelines. What are the barriers to physicians taking up clinical guidelines? And there's a number of studies looking at these things, and I'm just summarising some of these issues. One of them is that they don't even know that they exist. If they know about them, they may not be very familiar with their content. They may not agree with what they say. They may say, okay, that's a good idea, but I really lack the skills to be able to implement them. I have no sense of ability to implement these very well. They may feel that they don't have any expectation that outcomes will work, so they don't actually quite believe they will happen. Or their previous practice is so ingrained and so difficult to get out of that there's an inertia they cannot change. Or, if they're physicians in particular, they may love the drug therapy aspects, but the non-pharmacological aspects may basically be ignored. Or there may be a number of external factors and barriers. I hope some of these things are actually ringing bells with some of you. So the external barriers can include things like a lack of teamwork with other health professionals, because it might be very important to work with dietitians, psychologists, exercise physiologists, physiotherapists, but they may not have that teamwork set up. There may be a shortage of doctors, so they may not be able to implement them. They may be worried about malpractice, or they may have time and money pressures, which mean that they cannot implement these guidelines, which may take more time. Or, for a whole lot of reasons, they may place little value on prevention and health promotion in clinical practice compared with acute care management. That's particularly an issue in my country, where doctors are actually are paid by the government for services, and they get more money by throughputing patients rather than health promotion. So, and in addition to those which are well recognised and relate to a whole lot of chronic diseases, I think there may be a special case for obesity as well. I think a lot of, I think this is a real issue. I think there is prejudice about obesity, and many clinicians, probably not any of you here, but those outside of here who will be also involved in implementing guidelines, some of those may have a true anti-fat bias, and that can be detrimental to clinical care because a lot of the community has an anti-fat bias. They may have an opinion about obesity, not evidence-based, but they'll have an opinion about it and be quite emotional about it. Their own lifestyle may be vulnerable, and they may find it hard to tell their patients to modify their lifestyle if they themselves find it difficult. This is classic in the issue of smoking, but it may also be the case in terms of physical activity and healthy diet. And the other thing is about actual knowledge. Many physicians, and I might add other health professionals, are still poorly trained in the basics of lifestyle change, weight management, healthy eating, healthy diet, activity at both the undergraduate and postgraduate level. There may be the none of my business view, so physicians may see themselves as the coordinator rather than the person who delivers the intervention. They may not be able to categorise their problems as having a chronic condition. They may still be set in this is an acute issue. I'm going to treat it like acute asthma and it'll get better within next week, rather than this is a disease like diabetes or heart disease which needs lifelong treatment. And the other thing is that I think we have good evidence now to show that parents, health professionals, school teachers have a tolerance of weight shifts, that now the general community and health professionals don't recognise obesity when they see it. Let me show you. These are US police, these are photographs of groups of US police officers taken half a century apart. And you see the group in 1950 where there's a number of reasonably lean, normal BMI police officers, and the one about down the bottom in 2004, I think you could fairly say that probably every single one, perhaps bar one or two, was actually distinctly obese. And yet they would probably think this is our great police force. People are used to seeing big people now. So what approaches might work to increase physician and other health professional uptake of clinical practice guidelines? Well, we know a little bit about what might help physicians in terms of other areas, and I can see no reason why they may not work in obesity. So it might be reminders to doctors, say computer printouts with identifications of deficiencies in medical care and recommendations. It's interesting. Or computer-generated report on the patient's chart suggesting a weight reduction diet. So you put in your height and weight, you get the BMI, they say needs lifestyle intervention, say. Or training doctors to give advice. So, for example, psychologist support to actually learn some skills. Or assessment of counselling behaviour after individual training. Or shared care between a specialist and a general practitioner or a family doctor may improve clinical care. However, we're only really just learning where we might be in terms of implementing guidelines. It's a big, big challenge. So what may be the way forward? In terms of research, I'm just highlighting here some of those research questions that we mentioned before. Which of these are ripe for research locally? And I think there are some that are just crying out to be done here. So issues about the issues about what interventions work best for different cultural groups, countries such as Saudi Arabia, those studies need to be done here. I think there's a number of other things about looking at cost and resource effective methods of treating obesity in different settings. Certainly the bariatric surgery studies are ones that could be looked at very well here, and the issue about harms and benefits can be incorporated into any study. And what about obesity clinical guidelines? Perhaps, I could imagine that following on from here there may be a group who want to develop clinical practice guidelines and try to disseminate them throughout the kingdom. Well, if you're going to do that, I'm going to suggest that you have a good group of thoughtful clinicians who work together. You have people across the multidisciplinary team spectrum, and that you do a few things. You focus on outcomes, you use the best available evidence, and you look at the strength of recommendations. You need to recognise that from going from evidence to clinically useful recommendations requires good sense and judgment, so you need sensible people, and you need to involve a range of people. You need to be flexible, thinking about costs and constraints, so you can't say, well, we're going to look at everybody, we're going to provide everybody in the kingdom with 60 visits a year. That's not going to work. You need to, as you do it, think, well, we write the plan, but how are we going to disseminate it? So you need to think, how will practitioners, and I might add the consumers, the patients, their parents, become aware of them once they're developed? How are you going to make them available and teach people? You might need specific resourcing, perhaps from the Ministry for Health, to upskill and do CME on this issue. You might need to have training sessions and websites. You need to evaluate the implementation and impact, and you need to have a system for revising them. This is what you should do with guidelines. I finish now. Hopefully I've raised a number of questions for you and maybe some ideas for the way forward. And in doing so, I just finish with acknowledgement of our Cochrane Review team and the people who think about clinical guidelines and implementation of them back home in Sydney. Thank you.
Thank you, Professor Louise, and thank you for sticking with the time. Since we don't have time, we have to move on, and I would ask everybody if has a question to talk with Dr. or Professor Louise during the break time. Now we are into our second speaker, Professor Kevin Sykes from Chester University. His talk about diet, exercise, the ideal combination for effective weight management and its application in weight management program.
Well, good morning, everyone. I'm assuming if you get a text message this morning, it might be to ask you to do some exercise as a gentle reminder. What I'd like to do is just talk through some of the basic principles of including exercise into a weight management program, and then talk about some of the initiatives that we've had recently in the UK and how some of these might apply into Saudi. I have two particular interests. One is in weight management. My chair is in occupational health and fitness, so we see a lot of sickness and absenteeism in the workplace, possibly as a result of poor lifestyle in youth. So I'm also chair of the scientific chair of the British Association of Cardiac Rehabilitation, so I have a particular interest in hearts as well as weight management. Our problems in the UK are no different to anywhere else. We've got huge changes in obesity in our children and adolescents, and we know pretty much that those two factors are major contributory factors. And obese children have a tenfold risk of becoming obese adults, as we know, compared to normal weight children. We're all trying to work out what happened in around 2001 when the data shows remarkable increases during that time. The suggestion from my colleagues is that it's beginning to plateau, but certainly no signs of a decrease in the UK in childhood obesity at really all age groups. And similarly in type 2 diabetes, similar data showing increases there in most of the age groups, and still on the increase with some sign of plateau. And the new patients aged 10 to 18 admitted to hospital with obesity and type 2 diabetes has risen significantly since 2001. Well, we learned yesterday about the fine energy balance, and for most of us,